Welcome to the Health Insurance Innovation Summit's Inflective versus Reflexive Innovation Briefing by Shah. I'm primarily a systems architect and an engineer that designs and builds digital health and medical device technologies for a variety of different use cases. Recently, I've been helping support AHIP, that's America's Health Insurance Plans, which is the largest advocacy association for health insurers, large integrated delivery networks, and self-insured employers, as a technology strategy advisor and entrepreneur in residence. What that basically means is that I help AHIP's members navigate the landscape of innovation in ways that allows their strategies to be most effective. My pet peeve these days is the idea that anybody, whether you're a small company, a big company, the government, believes that there will be a disruption of any sort in the healthcare industry. It's my belief that small portions can be impacted positively, but it's really hard to disrupt healthcare. That's primarily because it's huge. Like this particular image shows you that what $1 trillion looks like and what $1 billion in comparison to $1 trillion looks like. Now, if you were trying to disrupt $1 billion market, that's understandable and probably achievable. But $1 trillion market, and of course healthcare is 3 times this size, is far more difficult. So I like to think about what one of my favorite entrepreneurs, and certainly an innovator, advises about how to approach innovation. And that is, figure out what's not going to change in the next 10 years and concentrate on that. So how many of you watched House MD? Let's see if we can remember the things that Dr. House was always fighting. Those are the things that won't change anytime soon, even in healthcare, which is why it's so difficult to disrupt the entire industry as a whole. As leaders of patients or clinicians or anyone else in the healthcare industry, if you steer clear of what's not going to change, you'll be able to say yes to more innovations and be more effective more often. So first, the idea that we cannot do any harm. We have safety first, reliability, and standard of care that doesn't change very often. We have a ton of statutory cruft and regulatory burdens that increase over time. The government definitely is going to remain the dominant purchaser, so it doesn't matter what happens, they are going to be the ones that are calling the shots in many cases. Outcomes-based payments and value-based care are growing, but intermediation and pricing pressure continues. Now, eminence and consensus-driven decisions continues because in healthcare, often it's not what you say as far as the evidence is concerned, but who you are. So if you're a big organization that has a lot of credibility, you're more likely to believe even if the evidence doesn't point to that direction. And lastly, we're going to be increasing a lot of use of alternate sites of care. So when you look at all of these about what's not going to change in healthcare and you say, well, how do I continue my innovation so it ties to it, you'll continue to be successful. So now let's talk a little bit about what I think about inflective versus reflexive innovation. Reflexive basically means that something is happening or done without thinking too much as a reaction to something. And it's basically characterized by habitual and unthinking behavior. Now, this might be a little insulting to some folks, but it turns out that the vast majority of what we call innovation in healthcare, especially in the insurance industry, probably is most reflexive rather than inflective. Now, what does that mean? Inflective means to turn from a direct line or course and to affect or alter noticeably. And this is the key. Noticeably means that we're doing something that's easy to see because we're making it turn on an inflection point. Now, to me, reflexive innovation is lazy innovation, and inflective is strategic. So what do we mean by that? Well, we often hear crazy things like, we need Uberization of healthcare, like that means something. We hear, we need to disrupt healthcare. That's not an innovation. Or we need to buy more digital health tools, as if that's going to actually make the case in any particular environment. Now, let's think about the inflective side. Real good questions are, for one example would be, how would elimination of copays increase utilization? How can improving provider affinity increase member satisfaction? Or how can we pay non-clinicians to handle more patient-facing tasks? These are all very important questions that would be more strategic in nature than they would be in the lazy reflexive model. So this is what we mean by inflective. When you're thinking through key inflection points on how a particular item changes because you're looking at it in a different way, that to me is a far more strategic way of innovating. Now, in the lazy model, the reflexive model, we're basically reacting to supply by what I call doing crazy faster. That means there's some innovation sitting in some other industry, you just grab it and say, okay, how's it going to work in my industry, without really tying it to your specific environment. And what we want to do instead is to truly influence demand. And what influencing demand means is that we understand in the health insurance industry what our needs are, and then tell innovators outside or inside our own organizations, what is it that we expect? What are our desired outcomes? What are our stated needs? Those are the things that happen to be very, very important. So let's look at what I think is a pretty good inflective innovation. Now, if you look at this headline, VA, nurse practitioners nationwide no longer need physician supervision, it's a great example. Now, whether you agree with this particular approach or not, such as nurse practitioners not needing physician supervision, think about the amount of innovation that can occur by simply inflecting on this point rather than saying, well, nurse practitioners will always be under nurse supervision, therefore we need tools to help with their workflow. We need to make sure that the teams of nurses and physicians are connected properly, and the number of innovations that would need to be required to be built on the idea that nurse practitioners must work under physician supervision would be quite different than if we made this particular decision. So when you look at this and you say that you can do away, for example, with team-based care that's been adopted at VA and reverted back to an outdated model of healthcare delivery, which is what some members of the American Medical Association are complaining about, that might be fully accurate. But what it points to is that if you look to what is actually causing problems in our environment, it's probably more related to workforce, probably more related to workflow than it is to the lack of tooling or lack of, quote, innovation that might be available. Let's look at another example. Now, the idea of member centricity or consumer engagement and the focus around it is very popular these days, and it absolutely should be. For example, getting a better understanding of the journey map for how needs assessments occur and recommendations of products occur. The idea that a health insurance company must work directly with its members and go through this process is something that is just assumed to be the case. But think about the idea of saying, well, what if we empowered our physician community or incentivized physicians to help our patients go through this process? That might change the way that we expect what tools we want to build, what innovations that we need to come up with, and basically try to say that could we eliminate certain problems that a member of ours would have if we got them to not talk to us as a health insurance company and instead got them to talk to the providers or others that they care about, nurse practitioners. It could be an entire retail setting in the case of like an Apple store where you can actually walk in and talk to people in person, get your answers. Is it better to have member centricity for consumer engagement directly through the health insurance company? Or should there be some other people in the middle that are actually doing the recommendations and doing the new member welcome education, health and wellness, and those kind of things? So what we need to think about is what is more inflective versus what is more reflexive. If we just have mobile apps available and we use them because we think it's a great idea, that is reflexive. If we say, you know what, we need to change the way we're thinking, that this is not a patient or a member would more likely trust someone else in the value chain, let's see if we can use them instead of us to get the most benefit to the member. Not the most benefit to us as an insurer, but the most benefit to the insurer. So this is a good way of thinking through what is a actual idea behind consumer engagement versus just a simple reflection of what other people might be doing. So this brings us to the question of what exactly is an innovator's job, especially at a health insurer? Are you a solution miner? Are you installing stuff? Are you an integrator of things? Are you an enabler of things? Are you trying to optimize something? What exactly are we supposed to be doing as innovators at health insurance companies? Well, I think that an innovator's primary job is to define desired outcomes tied to specific inflection points. So you may not be a technologist at all. In fact, that might be a great thing. Your job is to really find out, what do we actually need, instead of just what solutions are available out there. So as an engineer, one of my favorite historical figures is, of course, Albert Einstein. And I love this quote that he has, that if I had an hour to solve a problem, I spend 55 minutes thinking about the problem and 5 minutes thinking about solutions. This is the exact opposite of what, quote, some innovators, unquote, are doing these days. They're more thinking about, okay, how do I Uberize medicine, or how do I create more and more capabilities around digital, just because those are working in the airline industry or other industries. Now, those are good ways. I mean, understanding those are very, very important, but that's what you're doing when you're thinking more about solutions than you are about the problems. Now, when you're thinking about the problem, you're inflecting. When you're thinking about primarily the solutions first, then you're reflecting over what's available outside. Now, one other thing I always remind people is, another quote of Einstein is, stay away from negative people. They have a problem for every solution. So this doesn't mean that if there is a solution available and it's clear, that we somehow ignore it. But I think what's happening these days is that the Affordable Care Act, repeal, replace, all of this discussion that's going on, MACRA, MIPS, value-based care, outcomes-driven care, this is all driving us to think differently, but we keep thinking about what techniques and technologies are available today to apply to those problems, instead of saying, what can we do to rethink the problem and then apply the right technology to it? So with this, I've come up with a little how to be an inflective innovator formula that I think you might appreciate. So in the spirit of Albert Einstein, the IL is the innovative leadership formula. Let me walk through what this basically means. So the inflective innovation leadership score, where you're targeting a number greater than 1, is accommodated by starting with an inquisitive knowledge of outcomes led by curiosity about why things are the way that they are. Now, we often forget that the reason why things are the way that they are very, very good. You know, there might be something that is written in law. It might be because of the way that employers purchase insurance. There's all kinds of reasons. So we don't want to skip through and say, well, that's just crazy. We have to understand why things are the way that they are. The second thing is looking at visionary outcomes strategy. This is not just to say, well, I would love to be number one in my industry. How is that going to make you, how do you get to be number one in your industry, is something for you to put through by looking at your problems to be solved and your jobs to be done. The next is, how do you communicate and coordinate the desired and expected outcomes? Then, how do you apply actionable transformative technology fully integrated into complex workflows across stakeholders and institutions? And then, understanding performance, financial, and utilization risk. Risk is being shifted in a variety of different ways these days, and we need to keep track of that. Finally, execution through workforce optimization. So when you look at the numerator here, there's a lot of big components that I think that we'll be able to think through reasonably well over the rest of this briefing. But the most important thing, and which drives the score really hard, is the status quo. This is a constant. It is the size of which depends on your organization. It means the ideas of we're doing no harm, focusing on patient safety, the reliability, intermediation, all the things that we discussed of things that won't change. That's the status quo. So we want our inflective innovation leadership score to be as high as possible. And we have a lot of components up at the top, but the status quo, if that's really, really big, your score gets really, really small, because your denominator gets smaller and your numerator is smaller and your denominator is bigger. That we've had a little bit of fun here, let's get into serious talk about what innovators can use to define desired outcomes. Number one is understanding management objectives based on desired outcomes from your strategic plans. That's usually a great place to begin, is where are your strategic plans? Then you consider using objectives and key results, or OKRs, which is a framework for helping define outcomes. KRs are key results, O's are objectives, and the KRs with the O's together help you score and define numeric, measurable approaches for achieving some desired outcomes. we have to really understand our problems to be solved, what I refer to as PTBSs, that are tied to the OKRs, and assuming that we understand our objectives based on the strategic plans that we've been given. For each problem to be solved, you have to understand what jobs are being done today through journey mapping. As we figure out and model the problems to be solved and jobs to be done, we need to do so in either simple spreadsheets or real simulations. And I mean running a Monte Carlo simulation, some mathematical model that we can flex and move over time. We want to eliminate as many jobs to be done as possible through policy or process redesign. The example that I gave you about the VA saying that nurse practitioners no longer need physician supervision is a great example here. If you could just change one policy, what I call a stroke of the pen problem, if you create a stroke of the pen which says something is no longer required when it was before, enormous amounts of jobs can be eliminated that otherwise people would have to do in a wasted manner today. For the jobs to be done that are remaining, which can't be removed through policy, for example, regulatory, statutory, you've got a business model to be in, start listing out the remaining problems to be solved. Find or create solutions now based on remaining problems to be solved, jobs to be done, and journey mappings. This is where you start thinking about solutions, not at the first part, but now at this part. Test your hypotheses against the models you created earlier, and if you've got simulations, it's even better because now they can be evidence driven. So you can say, for example, I've got a simulation of 1,000 patients going through a specific set of steps through a group of workforce that is doing the work today. If I change some of my simulation, that might show me some different outcomes. Finally, when you've done all these are what you basically will see as your stated needs, what at the AHIP Innovation Lab we refer to as stated needs, primarily because you'll use that to influence the demand of any innovations that you come up with. Now, when you look at inflective innovation, it really requires outcomes to be specified. Well, what are the outcomes drivers for us in healthcare? There's a great Robert Wood Johnson Foundation article that described these modern healthcare outcome drivers like health behaviors, clinical care, air and water testing, air and water quality, housing and transit, education, employment, income, family. So when you look at these kind of things, they're broken up into health behaviors, clinical care, physical environment, social and economic factors. Now, as you run through these, you'll start to see, is my innovation that I'm trying to come up with tied to problems that I'm trying to solve in health behaviors? Is it around genetics? Is it around diet and exercise? Is it around tobacco use? If not, why not? If not against health behaviors, is it against clinical care? If not, why not? What am I tying? Where are the objectives and key results that I'm tying my inflection points to? So if it's not clinical care, could it be in social and economic factors? Am I trying to impact education, employment, income, family support, or communication safety? If not, why not? Where am I tying it if not these areas? And lastly, in the physical environment. So all of these things, when you look at where the inflection points are in the areas that we've talked about, we come to a really quick understanding that there are real challenges that have to be solved in healthcare insurance companies, and real innovators don't speculate. So the question is, who's going to tackle these challenges? So let me tell you about some existential challenges for us in the health insurance industry. One big question is, how can we understand real cost for more modern life tables? How do we increase transparency of costs across the supply chain? How do we combat information asymmetry, which basically means that sometimes physicians have more information than insurance companies do, yet the insurance company is taking the risk based on a lack of information. Sometimes patients have more information than physicians do, and physicians are taking on risks. So information asymmetry basically means one group has more information than another, yet the risk is not associated with the information at that time available. How can we be accountable for long-term care when our beneficiaries move freely between insurers? And then how do we take long-term risks in a low interest rate environment which has reduced our own investment income? So when you look at these existential challenges and you say to yourself, well, I'm going to go buy a mobile app that's going to help me with something, how does it actually help you with the challenges that are in place and can be tied through actual key results that are going to be easily responsive to? Let's look at some intermediation challenges. How can patients become strategic partners in their own well-being? How do we encourage members to take more responsibility for care without increasing out-of-pocket expenses? How can we empower employers to engage more with their employees' health? How do we empower providers without getting in the way of care? How do we increase collaboration across narrow networks and treat providers as partners and not suppliers? So you look at these intermediation challenges and you say, intermediation is not going anywhere, but I've got real problems to solve here that are not just going to be solved because I found a cool tool somewhere. Now let's look at some of the performance challenges that we have. How do we use behavioral economics to increase affinity with care providers? How do we define performance outcomes in value-driven contracts? How do we manage pharmacy costs without global negotiated rates? How do we catch fraud, waste, and abuse in real time versus retrospectively when it's too late? And then how do we get more participants in the healthcare ecosystem to take on more risk? These are real performance challenges that can't just be solved by buying something or saying we need to Uberize medicine. Now, when you look through this, let's talk about some of the specific ones. Today, we know that our life tables, which is basically the actuarial data, aren't granular enough. When you look at this kind of data, where health outcomes come from, you're looking at economic stability, neighborhood and physical environment, education, food, community and social context, the healthcare system. There are some portions of this that we've known for many years, such as based on your age and gender, you might know something about the mortality rates. But really, our life tables haven't been updated for many years, and because we don't have this level of granularity data. Payers, employers, public sector, we're not, as a group, incentivized to change long-term behaviors. And even the incoming Trump administration indicates decentralization is more likely to happening, potentially impacting our incentives. So when you look at this picture, think about these two areas where the funding institutions and the patient, those are the only two green boxes. Those are the only two places where money comes from. Everybody else is moving money around. Our question is, as we're innovating, are we looking at this big picture and saying, if I took money from one group to another, if I incentivized one group to another, moved incentivizing from one group to another, how would that improve my provider-facing solutions? How would that improve my patient-facing solutions? Do I have to do all the work as an insurer, or can I move it around in other places where patients and care providers might feel more comfortable? Continuing this theme, intermediation is growing and it's not shrinking, and it continues inefficient marketplaces between beneficiaries and funders, where health insurers often get their money, which is from employers or other funding sources. And the incoming administration wants more power in the hands of doctors and patients and less with government. So what can we do to help make that happen? How do we take our patient-facing solutions and empower patients more with them? How do we take our provider-facing solutions to help increase affinity with those providers, and so that they're doing the right thing at the right time for our members? Now, because no one funding entity or insurer has the beneficiary long enough to be accountable for long-term care, we have not just information asymmetry problem, but we have a problem that, based on what's happening at an age under 20 versus between 20 to 44 versus at 25 to 64 or over 65, we're spending money in different ways at different times, but often our innovations are one size fits all. So when you look at this particular graphic, look at an idea of the age, the type of healthcare, and the aggregated conditions that are occurring, and saying, where am I going to focus my innovative attention? Am I going to focus on musculoskeletal disorders for 20 to 44-year-olds? And if so, what would the innovation look like for them versus any of the other mixtures that you see here? So when you're looking at inflective innovation, what is going to make this possible? Why is innovation at health insurance so much harder than it looks? Much of it is because of the intermediation that I talked about, but really it's because we're not focusing on the inflection points. So what's easy to talk about, for example, is that the repeal of the ACA will be disruptive. Okay, but really adapting to the ACA's healthcare reform agenda, which is not likely to change, while continuing to focus on internal policy priorities, is really where we need to focus our attention. If you look at member growth inflection points, we want to allow more patients to enter into the insurance marketplace. But attracting the right kinds of, quote, profitable patients in a rapidly changing complex market will be difficult. So when you're looking at your specific innovations and seeking out vendors or solutions, ask more specifically about how is the repeal or replacement going to affect new patient entrants before you think about the solution that you're buying. As far as our products are concerned, we know that our aging populations and demographic changes are expanding the insurance marketplace. But really, it's unclear where the money for these new entrants is going to come from, because if the ACA repeal happens faster than the replace and Medicaid block grants move in, what are the innovations that you're coming up with, the tools, technologies, and things like that you're going to be buying? How are they going to apply in that particular environment? We all talk about cost containment being really, really necessary, but removing manual processes in favor of automation requires migration to cloud, focusing on integration, and providing more self-service applications, which we are nowhere near ready to do. Telemedicine, analytics, increased regulations, these are all simplifying claims processing, but they're causing priority conflicts because our IT people are busy doing other things. We really care about provider collaboration inflection points, and we want to increase that communication engagement. But connecting with providers that have complex relationships with their health systems and are seeking alternative care models, that requires a next generation thinking and technologies. That's not going to be done using the reflexive models that we've come up with. We have to find the inflection points. And then new payment models. We really know that we need to participate in alternative and often value-based care models, and we need to be more patient-centric, but it's really, really hard to deliver because most technology and processes are built around fee-for-service today. And if we don't help our providers understand that they are living in a fee-for-service delivery world, their workforces are all focused on fee-for-service, then just asking them to do value-driven care or shared risk contracts isn't just going to make it happen. Patient centricity is not easy to define or execute, and just asking for it or hoping that we put it into a contract is not going to help. So let's think about some advice for ourselves, as well as consultants and other service providers that might be jumping in to help. So what are the inflective innovation opportunities at this point? Number one, digital strategy can achieve your initiatives. So starting here in the areas where member solutions, where you're dealing with eligibility, authorization, and claim status, these are all good things. But think back to what we talked about where we said, if you can inflect and remove a job, so if you say you don't need to do eligibility checking or you don't need prior auth, or that claim status is automatically being transparently shared amongst all groups, that can eliminate certain kinds of work and then not require you to go build those kind of systems. So remember that we build systems that are tied to the old or new or different kinds of workflows that we demand. So someone should be sitting down before going in and buying new things or trying to achieve a new digital strategy and seeing what work can I eliminate? What are the strokes of the pen problems that I can just change a policy and remove a requirement for work to be done? That is your best innovation that you will ever come up with. There's a lot of opportunities in data comprehension, and this can actually help you figure out whether or not we are focused on the right areas, which is, do I have administrative and data collection data that I've got available? Do I have some phenotypic data? Do I have enough bio-IT and genomics? Now, a lot of physicians and health systems can't afford this kind of data comprehension work. So if you're in a place that you're doing this data comprehension for yourself within the insurance company, let's figure out how to bring in the other providers and share that data with them. There's a ton of opportunity in accountable tech. We know, for example, that the cost per patient per procedure treatment is going up, but we can't always explain why. We know that the cost for the same procedure and treatment plan is highly variable across localities. We're unable to compare drug efficacy across patient populations. There are a lot of problems here that can be solved simply by data comprehension and starting in the digital world if we focus on the right areas of attention. There's a ton of opportunity in new approaches and standard of care. Moving from general wellness to specific prevention to self-service physiologics. This is an area where many health insurance should start looking to self-service monitoring, to self-service diagnostics. You notice the self-service here being a lot more, where you're actually putting technologies into place which you can share with care providers to allow patients to do things on their own by working with their care providers, not in the absence of their care providers. Then there's care team monitoring, care team diagnostics, Healthcare professional monitoring, this is an area where, as far as the healthcare professional monitoring is concerned, people have done for many, many years, and this is what our standard of care currently is based on. So when we look at all of this, we start to see that innovation is determined by intermediation, and what we're trying to figure out is what statutory or regulatory modifications will really drive changes. If we can move from these two green box areas, such as the funding institution and the patients, we know that we're asking patients to take on more burden for their cost of care. And we know that the care providers are going to be doing more, care institutions are going to be doing more, the payer institutions are going to be doing more. How do we reduce the amount of intermediation by making sure these groups are working as a team instead of independently? That includes distribution, supply, and so this is a complex environment, which is why I said the disruption in healthcare is really, really hard. But when we start to say we're going to work as a team and that the health insurance companies can start to take on more burden as part of the ecosystem to say, okay, I will pay for these technologies if a particular group down the chain, for example, care providers or care institutions, will consume it and immediately in real time share data. So there are a lot of incentive models that we could put into place which would allow these to be put in pretty quickly if we said that we're working as a team. So the question is, how will the ecosystem pay for an innovation? Often putting in an innovation and allowing direct payment to be done through providers and the patients is obviously best. Direct reimbursement, second best option, and indirect reimbursement is actually very useful as well. So as health insurers, we don't necessarily have to pay for 100% of it if there was enough of a benefit to our providers and other members of the ecosystem to help reimburse some of that through utilization and reduction of cost on the health insurer side. So the question is, as you're starting to look at this, where does your innovation fit becomes a very, very important question. We have to target the right markets. So do we start with patient education? Do we start with patient administration, diagnostic tools, therapeutic tools, or therapies? Well, there's a lot of regulation associated with all of this. Some of the regulation is caused by us in the health insurance industry itself, so we can remove it. Some of the variations of the regulations is primarily due to statutory or regulatory environments. So if we found out that we have an inflection point, that inflection point has created a proper stated need, and then we start looking at regulations about how insurers can get involved in a number of these areas, could those insurers then make those tools available both to themselves as well as to the rest of the ecosystem? Then we all win together, which benefits the insurer as well as the members, such as patients. So lastly, we want to think about what kind of users are we targeting. So if we're looking this year, we could say, okay, Q1 of 2017, Q3 of 2018, we're focusing on these particular types of patients. Are they in the less regulated space? Are they in the more regulated space? Where is the cost going? So we often don't focus and say, okay, our innovation is tied to a large population versus the larger cost. And by looking at the populations properly, we'll notice that much easier. So in the end, what we want to look at is what problem are we really solving? What inflections are we looking for? Are we trying to actually focus on the medical science? If so, we can work with many, many groups that are focused there. Are we trying to improve access to care? Is telemedicine going to be good enough? Are we trying to reduce costs? If so, what could we do to help eliminate copays or coinsurance from our patients? Are we improving therapies by looking at genetic or regenerative medicine and those kind of areas? Are we looking at improving diagnostics by paying for diagnostic devices on behalf of our members? Are we trying to improve drug design or drug delivery? If so, are we working with the proper pharmaceutical companies? Or lastly, are we trying to create better payment models? That means that we are in charge of those and we can make that happen faster. Now, how do we identify the best opportunities? I like to say first look at the circumstance, then the context, then the constraints, then the compensating behaviors, and finally the criteria. So this is probably more for the innovators working specifically on inside smaller groups within health insurers, or if you have innovators outside as consultants coming in and assisting. But you have to figure out what are we doing, which inflection point is the circumstance going to cover? Are we reflecting on a context or a constraint that's already out there, or are we devising what that is on our own? What are our compensating behaviors so we understand whether a job is important enough to target or just eliminate? If people are spending money on certain things to solve a problem, and if you take the job away, is that easier to solve an innovation problem than trying to go buy a solution and installing it? And finally, the criteria. We, as far as our customers, and when I say customers, it could be patients, it could be consumers, it could be providers, they look at their jobs through functional, emotional, and social lenses. When we are trying to innovate, are we doing the same thing? Are we trying to come up with and looking at the lenses through those functional, emotional, and social lenses? There's a very good article at Harvard Business Review, which covers all of these 5 C's of opportunity identification for innovations. Very much well worth reading. With that, I'd like to thank you for giving me your attention today to learn about inflective versus reflexive innovation in the health insurance industry. And what I hope you got out of this conversation was that there are many, many places where innovation can be applied, but let's make sure we're applying it in the right place by making sure we are focusing on the inflection points that are influencing demand based on our stated needs within the healthcare industry, and not just looking at what a self-driving car might be doing, or what the Uberization of medicine might mean, or what a cool new mobile app might do within our environment. Because if we do a focus only on primarily the idea that a available innovation can easily be applied, it means we're trying to do crazy faster, which means that a technology is available. We don't want to look at why we're doing things the way that we are. We just know that we're going to do them faster. And so with that, I thank you, and hopefully you'll be thinking about inflective innovation across your health insurance marketplace over time more than reflexive innovation.